गुड इवनिंग सर। आप म्यूट किए हुए हैं सर।
हाँ, खोल दिए खोल दिए।
सर 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 so nice of you sir.
थैंक यू थैंक यू।
So nice of you. You have given a new kind of wave across the country.
That's right.
हाँ,
And
बड़ी
it is,
बात है।
it is becoming popular.
It will become popular, देखिएगा ना सर। एक महीना में देखिएगा सर क्या इसका हो जाता है।
अभी ही मार पड़ रहा है तो हमको जगह नहीं है अब।
हाँ हाँ, तो ब्लॉक कर दिए सर। आपने ऑलरेडी ब्लॉक कर दिया है सर।
2-4 दिन के बाद खोलेंगे, अभी तो ओवरफ्लो हो रहा था ना।
हाँ 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 हाँ
फ्लो हो
हाँ
रहा था
हाँ।
कि इस पर 100 ही अलाउड है।
जी जी जी
पढ़ाना पड़ेगा अपना ये स्पेस, तब ना ये करेंगे हम।
जी जी सर।
स्क्रीन शेयर करने से स्क्रीन शेयर करके इनसे पूछिए सब कि वो दिख रहा है नहीं।
सर से
हमसे नहीं पूछे, आनंद से पूछे, जो भी पूछना है आनंद से।
अच्छा अच्छा
टेक्निकल बात हम नहीं जानते हैं।
अच्छा अच्छा। तो शेयर हो जाएगा ना, इससे करेंगे तो
करके देख लिया देखो।
करेगा, आनंद करेगा।
हो जाएगा नहीं तो आनंद।
सुन रहा होगा।
बोले
हो गया ना।
देखिए दिख रहा है।
हाँ, विजिबल है ना सर।
हाँ हाँ, एकदम विजुअल है।
ठीक है सर, राइट।
आज वंडर साहब को भी कहें कि आइए।
जी सर जी सर, बहुत अच्छा बहुत अच्छा।
नंदिनी नंदिनी को भी कहें कि आओ।
बहुत अच्छा, नंदिनी मैडम को तो हम बोलना भूल गए। अब
हाँ,
इससे हमारा उतना परिचय नहीं, आप ही लोगों के माध्यम से परिचय है सर।
न-
हम्म,
आनंद आ गया, उसको जो कहना है कह दीजिए।
दिख रहा है।
आई थिंक वी आर ओके।
आनंद
आनंद,
गुड इवनिंग सर।
गुड इवनिंग, एवरीथिंग इज फाइन।
यस सर।
स्क्रीन दिख रहा है।
स्क्रीन दिख रहा है ना मेरा?
जी हाँ
दिख रहा
सर, दिख रहा है जी,
है।
दिख रहा
ठीक है ठीक है ठीक है ठीक है। चलो,
आनंद फोटो खींचते रहना, बुझे ना।
है। जी 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 सर, हम खींच खींच के मुंह डाल रहे हैं ग्रुप में।
नहीं फोटो खींचना नहीं, रिकॉर्डिंग भी करना है।
जी जी जी,
रिकॉर्डिंग।
रिकॉर्डिंग भी करना है।
हम लोग को जो बुक निकालना है, जो जैसा सर
हाँ,
बताए हैं, तो दैट बुक विल बी पब्लिश्ड एट द एंड ऑफ एवरीथिंग।
एपिकॉन में होगी, एपिकॉन में होगी सर।
हाँ सर, ये जो आप बता रहे हैं, आप
हाँ
जितने आप बताए थे ना, समराइज करके सबको
हाँ
फाइनली।
हाँ, आप तैयार कर दीजिए, बुक हम छपवा देंगे, कोई चिंता नहीं।
ठीक है सर, थैंक यू।
आपके नाम पर बुक रहेगी। और
सर आपके नाम पर होगा, हमारे नाम पर क्या है?
हम उसको ई कर देंगे, आईसीपी में, स्टेज पर, एपिकॉन के स्टेज पर उसको पब्लिश कर देंगे।
ठीक है सर, थैंक यू। तदीय वस्तु गोविंदम तुभ्यमेव समर्पिते। आप ही का ना। अच्छा, सर आ रहे हैं कि नहीं आज, डॉक्टर ठाकुर साहब?
नहीं सर, इस मीटिंग में वो सब हम अभी रोके हुए हैं, पॉलिटिकल चीज रोके हुए हैं।
अच्छा 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 अच्छा।
क्योंकि एक को बुलाने पर 3 को बुलाना पड़ेगा हमको।
जी 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 जी।
धीरे धीरे ये होता जाएगा।
अच्छा आनंद, सुन रहे हैं?
जी सर।
आनंद, ये बताइए क्वेश्चन आंसर कैसे होगा इसमें?
चैट बॉक्स में जाता है क्वेश्चन सर।
आ जाओ।
अच्छा अच्छा अच्छा
क्वेश्चन चैट बॉक्स में आता है सर।
अच्छा, ठीक है ठीक है ठीक है।
जी जी।
हम्म, हम्म।
अब अगला हफ्ता से हम संजय जी को भार देने वाले हैं।
जी
संजय।
प्रणाम सर।
हाँ,
नाम।
गुड इवनिंग, क्या हाल चाल?
हाँ जी, नमस्ते सर, एकदम बढ़िया सर, सब आपका आशीर्वाद।
आपको प्रभार मिलने जा रहा है सब कुछ का। सर को
सर
छोड़ दीजिए। सर
सर
मीटिंग।
सर प्रभार नहीं सर, आदेश। बड़ों की सलाह ही मेरे लिए आदेश है।
हम्म, हम्म,
अकेले हम कितना सकेंगे, कहाँ कहाँ सकेंगे।
नहीं नहीं सर, एकदम सर निश्चिंत रहिए सर, हम लोग आपके आपके साथ खड़े हैं सर, जैसा जैसा कहिएगा वैसा करेंगे।
चलिए चलिए चलिए, यही सब सुन के तो मन खुश हो जाता है।
नहीं, अजय सर तो हम लोग को जानते ही है, अजय सर कोई बात हम लोग थोड़ी उठाते हैं।
ना ना, आप तो यू हैव डन सो वेल राइट फ्रॉम द बिगिनिंग।
अच्छा, आज सुशांत से हम बात किए हैं भैया ना, हम
जी
उसको
जी।
बोल रहे हैं कि 2 टॉपिक भेजो, तो कहा जी सर भेजते हैं।
हाँ ना, सुशांत से कराया जाएगा।
हाँ हाँ हाँ।
नेक्स्ट कराएंगे उनसे ना, आप संतोष से ना, आपके आशुतोष
आशुतोष
से ना।
आशुतोष से 2 क्लास है, हाँ।
ठीक है सर, ठीक है सर, 2 कंसेक्यूटिव क्लासेस में आशुतोष।
हाँ,
हाँ।
कराना तो आपको है, लेकिन हम भी थोड़ा लगे रहते हैं।
नहीं सर, आप बस, आपके स्ट्रेंथ के बिना थोड़े होता है काम हम लोगों का।
सर सर इतना इतना वंडरफुल प्रोग्राम है सर कि तो सही में मैंने आज तक का कभी आदमी सोचा नहीं था कि कंटिन्यूअस क्लासेस होगा।
हम्म।
इसी में तो बुढ़ापा जवानी में बदल रही है जी।
बिल्कुल सर, बिल्कुल सर, बिल्कुल सर।
बैकग्राउंड बदल सकते हैं क्या हम लोग इसका? खराब लगता है। चूज ए वर्चुअल बैकग्राउंड। वर्चुअल बैकग्राउंड ब्लर। इसको बंद कर देता हूँ, इसको बंद कर दूं ना?
हाँ, कर दीजिए।
हम्म।
अजय जी, ये क्लास सिर्फ टीचर और विद्यार्थी के लिए है, भैया ना।
जी सर।
कोई भी वीआईपी आई है वो हम नहीं लिए हैं।
जी सर, जी सर।
और एक आध गो कोई एक्सपर्ट आ जाए तो ठीक है, लेकिन दैट्स ऑल।
जी जी जी। लेकिन इस वाले में तो सर है ना, गुरप्रीत हैं आज वाले में।
इसलिए कि कार्डियोलॉजी का है,
हाँ।
कार्डियोलॉजी का इसलिए बुला लिए हैं।
जी सर।
नहीं सर, सर के कहने का अर्थ है कि ज्यादा क्वेश्चंस वगैरह हम लोग को विद्यार्थी सबका टेकअप करना है।
चेकअप करना
बिल्कुल
है।
बिल्कुल बिल्कुल।
अगर कोई एक्सपर्ट कमेंट अपना देना चाहता है तो वो ठीक है, उससे उसका हम लोग लें, लेकिन क्वेश्चन और लोग का उतना नहीं लें, बल्कि विद्यार्थी सबका जो बेसिक क्वेश्चंस है उसको ज्यादा
ज्यादा टाइम विद्यार्थी ले।
लें जी।
ज्योतिर्मय।
टाइम हो गया सर, शुरू किया जाए।
हाँ, ज्योतिर्मय अभी तक ज्वाइन नहीं किया। 1 मिनट।
वाह, नंदिता तो शायद आ गई हैं आपकी।
हम्म।
नंदिता है इसका।
तो कहे हुए
Good evening, sir.
खुश रहो, खुश रहो, खुश रहो। ज्योति भाई कहाँ है ये?
Sir is on the stage actually in Diabetes India. Uh,
नमस्ते
he can
नमस्ते।
join just
नमस्ते।
Namaste, sir.
खुश रहो, खुश रहो।
हाँ,
ज्योति उठा नहीं रहा है नन्ही, तुम फोन करो ना। He must be busy. Jyoti is not responding. Let's just start, Ajay ji.
पापा इनका फोन दीजिए।
Dr. Ajay. Jyoti is not responding, so we can start. He will come in between, okay? Good evening, friends. In certificate course, today is day of cardiology, and your teacher, Dr. Ajay Kumar Sinha, is here. My
शेयर करना है ना
शेयर है सर।
ये।
सर आप म्यूटेड हैं सर, सर आप म्यूटेड हैं।
it is time to start the course.
यस सर यस।
Day of cardiology, and our teacher is Dr. Ajay Kumar Sinha. Paul has not joined because of some urgent work. So Nandini is here. I will request Nandini to say something about this course. Nandini, please. Dr. Nandini, mute. Dr. Nandini.
yes, sir.
Yeah, say something about this course.
Yes, sir. Actually, this is a very beautiful venture that the ICP has taken up to have such classes, and it is quite unique in the way that it is being done every single day of the week and taking into account different topics on each day. So, and the physicians who will be attending as well as the students, I think they will be greatly benefited, and I congratulate Dr. Kamlesh Tiwari and his whole team for thinking about this and continuing, and I hope immensely success. Thank you.
Thank you, Nandini. Dr. Ajay Kumar, Dr. Sanjay, Dr. Sanjay. Dr. Sanjay, Joint Secretary,
Yes, sir.
say something.
Good evening, everybody. It is really very heartening to see that a education program like this ICP short course is going on. It is well conceived, well framed, and well timed. Learning is a continuous process, and not only the students learn, but we also learn from these classes. So it is really a wonderful program. I wish all success to this program. Thank you.
And now it is time for Dr. Ajay Kumar Sinha.
Thank
Kindly.
you, sir. Good evening. Dr. Kamlesh Tiwari sir, my friend Sanjay, and our erudite colleague Dr. Nandini. So let me begin with see what I've in a very short time I've tried to collect some of the information which is happening right from the historical background to whatever is happening today. So let's start our talk with
सहना भवतु सहनो भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै ॐ शान्ति शान्ति शान्तिः
So let me thank Dr. Tiwari and everybody who is present here. And let me thank Dr. Jyotirmay Pal for his help and inputs. We were there in that meeting, the inaugural meeting of this program. So this was the first meeting we did when Dr. Jyotirmay Pal and everybody was there. And this was a very a splendid start. I would say that a lot of people had given their opinion. And in today's meeting also, we have requested Dr. 2-3 doctors as per advice of Dr. Tiwari to give their comments if needed. So let me begin with the slogan exercise, the vaccine for heart. When we were attending a meeting in Bhagalpur, this was the picture of the photograph of that event, and I thought, what would be better than this to have this picture to emphasize that point that exercise is really a vaccine for the heart. And it was so exciting that I requested our colleague, Dr. D.P. Singh, to write an article in one of the newsletter or textbook, I don't know, I don't remember, that you write an article on exercise, a vaccine for the heart. Now, my talk would be, it will be confined to, not only confined to the cardiology, pure cardiology, but it will be covering up many things which are emotional. This gentleman who was given the first pig heart, and he survived for quite some time. And this was a genetically modified pig's heart. So that's what we are. We are today inching forward to a stage where we can do a lot of miraculous things. I thought, why not include my Sudhir Chaudhary as the first thing he said, that the salt is the biggest killer, not the... So how salt causes hypertension, salt causes atherosclerosis, and in Indian women, the salt intake, average salt intake is about 7 grams. And it would be something like 8.9 grams for males. So salt is the biggest culprit. It causes hypertension, it promotes atherosclerosis, and it is causing a lot of morbidity and mortality. I would like to draw your attention on a very important issue, that what are the risk factors as per Inter-Heart study in first myocardial infarction. And you see that lipid is about 50% of them, and all 9 risk factors in about 90% patients. So central obesity is a issue which is we call it treasure in tummy, and this is very, very important for all of us, those who are practicing medicine or cardiology or preventive medicine. We have to understand the importance of central obesity, and very simple, equipment which is required is a measuring tape. You can measure the girth of waist circumference, and if it is more than 90 centimeter in males and more than 80 centimeter in females, that is a marker of future problems. Now, let me begin with a very illustrative example of ECG. This ECG is of a 25-year-old male brought in emergency room with severe hypotension. Past history of recurrent palpitation was there, and he was given verapamil IV. What happens? This is the situation: hypotension with a broad, complex, irregular tachycardia. What we call it FBI, fast, broad, irregular. And this is the manifestation of accessory pathway in atrial fibrillation. When somebody gave IV verapamil, the AV block happened, and then through the accessory pathway, you are having conduction, and this is a very dangerous situation. So what to do? There are 4 choices. So my dear students or my colleague or whosoever is here, what is your choice? Cardioversion, IV amiodarone, IV adenosine, or IV dilgem? See, we don't want to give anything which will block AV node. So choice is cardioversion. Another case I wanted to put is very, very important, like a 85-year-old male, normal heart, normal echo, and this is the ECG. This is classical ECG of atrial fibrillation. Fast RR interval is variable, no P wave seen. So what is the choice of treatment? Is it aspirin? Is it aspirin and clopidogrel? Is it oral anticoagulant? Or leave him alone? He is too aged. Why should we bother? So, dear colleague, the choice is oral anticoagulants, because you calculate Chart's VAS score and then you give oral anticoagulant. Now, coming to a very, very important pertinent issue these days, that is sudden cardiac death. And the definition of this is death happening, sudden cardiac arrest happening within 1 hour of symptoms. And this is a very, very important issue now, that you see sudden cardiac death happening, all the big shots, big people are suddenly dying, in the gym or in the public place or in the playground. This is a very important issue. You must have heard that KK, that artist, died in Kolkata of sudden cardiac death, and nothing could be done because nobody knew how to do CPR, cardiopulmonary resuscitation. So I request everybody, all of you who are erudite people in the API, to take this point. See, if sudden cardiac death, like 70% of them are ischemic heart disease, and 10% each of non-ischemic structural heart disease, channelopathies, and non-cardiac causes. So that's very important to understand. Now, we did a program on sudden cardiac death in young, and this was organized by us, wherein Professor Mary Shepard, who is the ace lady in cardiac pathology in UK, and she elaborated this fact very well, that a good number of people are dying sudden cardiac death, and then different pathologies could be found in them. And she does pathology, and then she has a collection of some 5,000 odd heart specimen with different causes. Now, my own presentation at ESC Congress in August 2018, where the topic was, is there any progress in the risk stratification for sudden cardiac death? Very difficult. Still, we are groping around. And we say that wider QRAs or ectopy or bad LV, there are many caveats. So that's a very important issue. Now, we did a lot of programs in Patna, collaborated with many organizations like Revive Heart Foundation and all. And then we realized that, this is a very important education, which this lady is a ward counselor of our ward. She is doing CPR. She is undergoing CPR training. And we did the same program for the school. And we could find that they were very, young boys were very enthusiastic in learning.
Namaste, I'm Sara Ali Khan. CPR is an art that can easily be learned. If CPR is administered at the right time and in the right manner, the cardiac arrest patient can be given a new lease of life. Every cardiac arrest patient should be given that chance, and you could be the CPR hero that provides it. Let us all pledge to learn the simple, life-giving art of CPR and help to strengthen our country and its people. Log on to Revive Heart Foundation website and register to learn.
So my question to all my dear students is, what is the survival rate of out-of-hospital cardiac arrest? Obviously, it is around 10%. And this 10% remains all over the world. Despite all the developments and in science and learning and everything, still the out-of-hospital cardiac arrest survival is around 10%. So my final submission on this issue is that along with lifestyle changes, we must raise the awareness level about sudden death through public education, and wellness promotion, a priority should be there. Most importantly, each one of us should learn CPR and administer it within 6 minutes. Sooner you do it, better is the outcome. And AED, availability AED is very, very important. And then only we can reduce the incidence of sudden death in our country. Now, coming to some historical background, even the ancient mummies prove heart disease was there thousands of years back. You can see that coronaries are calcified. And the first, I would go into the history fast. Some of the, like William Harvey was the first person who hypothesized and gave his concept of circulation and heart. And so 17th century, William Harvey described circulation and heart. And then a stethoscope was described by René Laennec in 1816. It was not until decade from 1895 to 1905 that three clinically important technologies there were big technologies like BP machine, sphygmomanometry, electrocardiography, and radiology led to birth of a cardiology as a medical specialty. So 1920 was the critical year which marked the change of paradigm, and then cardiology coming as a specialty. And this is the story behind the development of a stethoscope. And the act which Laennec will never be forgiven by his fellow colleagues. That's very important. This was the way people used to auscultate. Another very important development which happened in 1911, 19 to 2020 was the electrocardiography machine by Eindhoven. Although before that, Mr. Waller, who said that it's not possible to use this very extensively in every hospital. But then the gentleman got a Nobel Prize for this discovery. And this is the picture of that gentleman. So in those eras, the therapy was limited, as William Osler recommended, a quite regulated ordinary life, free of excitement and worries. An ordinary wholesome diet in moderate quantities. Tobacco may be allowed in moderation, but alcohol should be interdicted. That's the statement of William Osler in those days. The only cardiac surgery was a stripping of pericardium. And in those days, eras and management was based on clinical experience rather than prospective hypothesis testing, randomized controlled trial. The root of contemporary cardiology started in 1924 with the birth of American Heart Association. And by mid-20th century, atherosclerotic cardiovascular disease, acute myocardial infarction, started emerging as most common cause of death in industrialized nations. Cardiology practice has changed over the past quarter century, and imaging has reduced the need for diagnostic cardiac catheterization. Catheter-based percutaneous intervention have reduced the need for surgery for many forms of congenital valvular and coronary artery disease. Cardiac surgery continues to play a critically important role in care of patients with more complex and serious disorders. This was the birth of cardiac catheterization by Claude Bernard, great French physiologist who measured the intracardiac temperature and pressure in a variety of animals. This is the classical picture of gentleman who invented balloon angioplasty, although he did not survive long, but he is remembered still today. Now coming to hypertension, high blood pressure. You see, there are so many viewers. Hypertension has become one of the most important cause of morbidity and mortality in the world today. If you see this, how blood pressure was measured, and this is known as Hale's horse, the first documented measurement of intra-arterial pressure. And then was the evolution of the discovery of sphygmomanometer. And this is very interesting that you see these three people, three of them were hypertensive. And in those days, if you see the President Roosevelt from USA, his blood pressure, how did it rise? See, on the day of election, it rose. On the D-Day, it rose. And finally, in that Yalta meeting of these three people, the very important meeting, 45, the BP rose to a very high level and he succumbed to it. So that's very important that in what Paul Dudley White said is that hypertension may be an important compensatory mechanism which should not be tampered with. See how silly was the statement. But then you can imagine Paul Dudley White was the father of preventive cardiology in those days. And his statement was that it's an important compensatory mechanism, should not be tampered with. Even we are certain that we are able to control it. So that's the statement, and that so high blood pressure being the most important cause of problems, mortality, and daily lost. This is the scenario. High blood pressure contributes to about 1,000 deaths per day. India has got huge population of hypertension. 1 in 3 adults are hypertensive. That's a very sad part. And we did, I was lucky to be in this study, which shows that the Great India Blood Pressure Survey, which showed that 1 out of 3 people are having hypertension. So many trials which have come on antihypertensive, right from VA1, MRC, DAS, and so on, HOT, SEP, Accomplice, and so on and so forth. So treatment of hypertension continues to be a difficult task in present. Can we move it from here? Yeah. So treatment of hypertension continues to be a difficult task in the present stage of knowledge, but important studies in progress offer much hope in future. This was a statement of Paul Dudley White. These are the various guidelines, and all of them have, established that blood pressure of more than 130 by 80 is abnormal, and except for the age 65 years and above. And various guidelines have given thoughts like this. The Canadian guidelines are very strict. ACC in 2017, they have said that the limit should be 130 by 80. There are various guidelines and their recommendation. We have Indian guidelines also, which also says that normal blood pressure is less than 120 to less than 80 diastolic. And the very important point is that, when you start giving drugs, first line drugs can be, there used to be 2 drugs, If you give a 2-drug combination, then only you're going to be successful. And FDC recommended first-line therapy for newly diagnosed stage 2 hypertensive. So everybody knows how to treat hypertension. Everybody knows how to treat hypertension except experts. But this is very important information on this slide, that we have to know how to check the blood pressure, how to take the blood pressure, what is the position of the person, what is the cuff size, how is he sitting there, and where is the feet, and all those things. And this, what is the equipment? So validated electronic upper arm cuff or manual auscultatory is the choice. And then you should have an empty bladder and relax for 3 to 5 minutes. Three measures. So these are the tips and tricks of taking blood pressure and do and don'ts. I just want to highlight this point, that number doesn't matter. What is the variation? So systolic blood pressure variation is variability is extremely important. And it has been seen that those people who have got a lot of BP variability, so just not depend on the number, depend on many other things, many active phenotypes, which will decide which are the patient going to have problems. So this is a study which shows that in 2020, this study came in JACC, that those who had a lot of variability, they had a lot of changes in the brain on MRI. So what I mean is we have to consider that blood pressure is thus not the number. What is how is the blood pressure in 24 hours? What is the circadian rhythm? What is the BP variability? What is the nocturnal blood pressure? All these things will make a sense when you are deciding about. So hypertension is just the tip of iceberg. You see 16% of ischemic heart disease, 20%, 1% of peripheral vascular disease, 24% of acute MI, and 29% of strokes. Hypertension is responsible for these things. But then what we are seeing is just the tip of iceberg. So we have to be very, very cautious. Coming to the advances in non-invasive cardiology, we have been doing quite a good number of procedures now. Transthoracic echocardiography, stress echocardiography. That stress echocardiography has changed our thoughts. In fact, we are now doing a lot of stress echocardiography, and we see the dynamic diastolic function during the stress. That's very important, because that will tell you, even if you have a resting ECG, resting echo, which is normal, resting diastolic function, which is normal, but the moment you exercise the person, you get all those parameters which are abnormal. So that's very, very important. Again, transesophageal echocardiography is very, very important now. It gives you a complete picture of this thing. Plus, it gives you an idea of LA geometry, left atrial appendage geometry, presence and absence of clot, and all those things. Now, recently, strain imaging has come in a big way. And you can see that now we are doing a lot of strain imaging, which tells you about the LV function even much before the LV ejection fraction decreases. So that's very important. This is true for all those patients who are having, a chemotherapy for cancer, especially breast cancer and all, chemotherapy. You see a lot of people, a lot of them will have decrease in LV function. Before that, you have abnormal strain imaging pattern seen in the echocardiography. Now, 3D echocardiography is now becoming more and common. Pediatric echocardiography is now picking up. We have a dedicated department of pediatric cardiology, and pediatric cardiologists are doing a lot of, like 1 day old infant had a coarctation which was dilated, and the child is doing very well. Like this, there are so many examples. And of course, intraoperative echocardiography, nothing to say about it. It's a very important modality. Now, this is just to highlight that strain imaging has got a lot of prognostic and diagnostic value. And Dr. Sardar Ranjan, are you there?
Yes, sir.
Oh, you are there. Good, welcome. You can give a quick comment on this, because you are the master of echocardiography in our lab. So
yes, sir. As you rightly said, the echocardiography has advanced a lot, and the importance of diagnostic cardiac imaging, new modalities, it is so immense nowadays, because it is an era of precision medicine now. Now it's not like that we diagnose just on, obviously experience and clinical has to be there, the clinical examination and history taking and the experience of the doctor, that has no comparison. But with that, if we add the advanced echocardiography and diagnostic techniques, it gives immense diagnostic answers to us. And strain imaging is the new modality in it, and it has a strain is something where we catch subclinical LV dysfunction, because if we know that, okay, heart failure, when it has reduced ejection fraction, we know, okay, now EF has declined. But if we can know that, okay, this patient ejection fraction will decline after 5 years, and we can catch it right now, that will be just amazing. And in the era of preventive cardiology, so strain imaging shows us that it has if the strain is low, global longitudinal strain, what we call it, if it is low, it means that the myocardium of the LV, left ventricle, or sometimes left atrium also we are doing it. So it is not so healthy. So that we can call it in an easy term. And it has shown a lot of role in chemotherapy induced LV dysfunctions, and then how to diagnose restrictive cardiomyopathies, because there we had no answer, because on looking, the ejection fraction of restrictive cardiomyopathies looks normal, but myocardium is not healthy. It has been replaced by something else like amyloidosis, or sometimes some fatty infiltration or something. So their strain gives us very lot of information.
Thank you, Shraddha. Thank you so much.
Thank you, sir.
We take your help as the things go on further.
Sure, sir.
So this is a story of a 55-year-old male referred for with a complaint of breathlessness, anemia, body ache for the last 6 months, LV hypertrophy on 2D echo, GLS suggests cardiac amyloidosis. What a fantastic diagnosis. So that is the beauty of, strain imaging and advanced echocardiography. Suspicion of intracardiac shunt on transthoracic echo, and this was confirmed on saline contrast that the gentleman had a sinus venosus ASD on TEE. So transthoracic echocardiography is a common phenomenon in our lab now. And you could see that the diagnosis of sinus venosus ASD was done. LV apical clot detection, LV clot confirmed by contrast. So this is again a reality now. Detection of reversible myocardial ischemia. And now 3D echo has come in a big way. We are doing regular 3D echo, which has given us a real anatomical picture in 3 dimensions, like fenestrated ASD or core triatrium. So these are the, some of the examples of how we have evolved in a structural heart disease. Severely calcified bioprosthetic aortic valve, a plan for TAVI. Now we are doing trans-aortic valve implantation. And that is this echocardiography is of immense value. This is the echo. This is the gradient before the procedure, and this is after the procedure. So echo does help us in deciding what to do and what not to do. Do and don'ts of TAVR. And again, the newer thing which has come up is known as mitra clip. This is again, this is of a great value in deciding and localizing and defining the anatomical abnormality and where to put the clip. So with this background, now we come to another point, like how much time we have spent, quite a bit. So ECG correlation with clinical cases. Thank you, Shraddha. I will take your help later.
Thank you, sir.
Abnormal ECG with normal heart. See, this gentleman had is having, looks like atrial flutter, and somebody referred like atrial flutter, but this turned out to be 2 P waves, one from the recipient heart, another from the donor heart. So this is a classical example of a transplanted heart. So donor's P wave and recipient P wave. ECG which may indicate threat of life. This kind of ECG is very, very, very alarming. This is known as tomb stoning. This is acute anterior wall MI with so much of ST elevation. We call it tomb stoning. And this is a manifestation of a very severe kind of ischemia, myocardial ischemia, and we have to act fast. This is another example of this. What is this? We have already shown this ECG to you in the beginning. This is atrial fibrillation with ventricular pre-excitation, fast, broad, irregular, FBI. And this is a manifestation of what? Accessory pathway with atrial fibrillation. This is a wide QT, prolonged QT interval, and there can be many types. We have to be very, very cautious. There can be acquired QT interval prolongation also. That is very important. And different type of QT interval prolongation, they have a different phenotypes, and that is. And then finally, ICD is recommended if about a certain cardiac death. Beta blockers can be given if QT is more than 500 millisecond. This is again a very classical ECG of Brugada. This is an autosomal dominant condition, more common men and Asians, and this is life-threatening condition, which can be picked up by ordinary ECG or provocation. Another ECG with LVH and T wave inverse. And this is a hypertrophic cardiomyopathy. And this is another ECG with anomalous origin of left coronary artery from pulmonary artery, and this is a condition which can lead to dilated cardiomyopathy, and this is a condition which is treatable and salvageable. This is a classical example of arrhythmogenic right ventricular hyperplasia or cardiomyopathy, wherein we see the epsilon wave. If you see this is a epsilon wave here, and T wave inversion in V1, V2, V3. Coming to acute myocardial infarction, not going to give you a detail of it, but then we have to understand that it can be ST elevation myocardial infarction, it can be a non-ST elevation myocardial infarction, and depending on the location, we can divide it, and we can locate and we can find out which artery is involved. This is a classical example of ST elevation MI. Post-thrombolysis, very important. So thrombolysis in the peripheral setup is the answer, even now. Till we have facility of primary angioplasty in every district town, we have thrombolysis, the answer for ST elevation myocardial infarction. Different valence criteria, normal mild ST elevation in contiguous lead, biphasic or T wave inversion, Deventers waves. Again, these are the manifestation of acute LAD occlusion, left anterior descending artery occlusion. Now, management of MI is early reperfusion. There is no doubt about it. And time is muscle, we know that. So I would think that in coming time, if somebody is able to make a diagnosis and if you are able to give thrombolysis on the way in the ambulance, that would be great. One of my patient in my clinic, like inferior wall MI, who was thrombolized with this white tenecteplase, and you see ECG is absolutely normal. You are not able to, you cannot define that this lady had MI. Coming to this, ST elevation and in diffuse concave ST elevation and ST elevation across the multiple leads, except AVR and V1, PR segment depression is also common. This is a classical finding of pericarditis, and classically 40-year-old male, sharp pleuritic chest pain, worsens while lying down and improves when sitting up. And this is the gentleman, 55-year-old, sudden severe chest pain. 10/10 means severe chest pain. And tall voltage LVH and secondary repolarization abnormality. This is a classical presentation of aortic dissection. So we have to be very, very sure about it. And this is very simple to pick up, even with 2D echo. Shraddha, can you comment, quick comment on this? Shraddha? Okay. Anybody who is here? Gurpreet, are you there? Okay. So this is again.
Can you hear me, sir?
Yes, yes, yes. Yes, yes. Tell me quickly. Can you by just 2D echo, you can find out dissection? Oh no, I'm not audible. She's not. Okay. So coming to the various arrhythmias, this is AV nodal reintrant tachycardia, where the slow and the fast pathway both are in the AV node. And you can see that no P wave is visible. Whereas AV reentrant tachycardia, pathway mediated, this is, you see P wave away. So what is this magic number? Magic number is 70 millisecond. If you are beyond 70 millisecond, you are probably dealing with AV nodal reentrant tachycardia. And atrial tachycardia will have P waves before this thing, but they will have abnormal morphology. So these are the 3 differential diagnoses of narrow complex tachycardias. Bradyarrhythmia, there are many types of bradyarrhythmia, like first degree heart block, second degree heart block, second degree Mobius 1 or Mobius 2, and there can be complete heart block as well. Hypertrophic cardiomyopathy is a very important issue. Hypertrophic cardiomyopathy is a very important issue. You can see that syncope on exertion, that is a very classical sign and feature of hypertrophic cardiomyopathy. And ECG is very classical. Now coming to some facts about the heart failure. This is the ladder of the treatment planning of heart failure. You can go from risk factor reduction to ventricular assist device and transplantation. And in between, there are so many drugs now available, right from ARNI to SGLT2 inhibitors. So this is the classical diagrammatic view of what ARNI is doing. ARNI is putting wheels in the donkey's feet. And this was the first trial which proved that in 2015, this was a trial which proved that heart failure is taking failure out of heart failure. This was the statement of paradigm heart failure. And after that, we are knowing that this is the classical 4 pillars of heart failure management, systolic heart failure management, where the last one is dapagliflozin. It could be any gliflozin, it could be any SGLT2 inhibitor, but these are the 4 pillars. And you see, the more you leave the heart failure, the less are the chances of survival. And every heart failure hospitalization is worsening the heart failure. That's very important. So attack the heart failure in the beginning. Give the drug, optimize the drug, and then you will definitely get the advantage of it. Cardiac resynchronization therapy, again, this has come in a big way. This is being done regularly now. And the portable LVAD devices, again, this has become a reality now, that people are moving with LVAD devices, waiting for the transplant, or this can be even destination therapy, where you can have it for a longer period of time. Heart failure with preserved ejection fraction, very important issue. That is a issue which is still not very clear, and we are trying to find out and dig in more and more on this issue. And you can see that arterial stiffening is the most important factors. LA myopathy is another one. Pulmonary vascular disease, obesity and cardiometabolic situations, they are all important in diastolic heart failure. And this is how the diastolic heart failure progresses. Decrease LV relaxation, decrease LV compliance, and decrease LA compliance, LA remodeling, atrial MR. That's very important issue. Atrial MR, mitral incompetence because of atrial disease. That's a very important thing. and then finally RV contractibility, and then finally severe pulmonary hypertension, and there can be atrial fibrillation, intermittent to permanent. So atrial fibrillation is almost, atrial fibrillation is sine qua non, just like a diastolic heart failure. That we have to understand. We have to understand that if you are managing the atrial fibrillation very well, you are preventing diastolic heart failure, you are preventing systolic heart failure. So this is the schematic diagram of treatment of heart failure with preserved ejection fraction, diuretics, SGLT2 inhibitor, ERNI, MRA, and L. So this is how this in diastolic heart failure, after diuretics, we have SGLT2 inhibitors now. Now, I have already discussed with this. I'm just going to tell you something about pulmonary embolism. That's very important. And we have to understand that anybody who comes with, emergency with dry cough, chest pain, short of breath, we have to suspect pulmonary embolism, and echo makes our job, has made our job easier. Like you can find out dilated RV, RA, and pulmonary hypertension, and CT chest or pulmonary angiogram can establish the diagnosis. Treatment is very simple. You try give heparin and then anticoagulation and interventions which are done in the lab. So this is the ECG, classical ECG of pulmonary embolism, what is known as S1QT T3 syndrome. This is classical, but this is not found in larger number of patients. This is found in only 20-30%. That's very important. So this is this patient echo finding, and then large LALV, tells you that pulmonary pressure has gone high and LALV is dilated. Another example of a retired banker of 66-year-old, and you see diabetes, hypertension, TIA, CABG, found to have anticoagulation, atrial fibrillation, started on vitamin K antagonist, anticoagulant. It is hard to keep INR in therapeutic range. That's the problem. If you're using vitamin K antagonist, it's difficult to maintain INR, and then left VKA. So he suffered a massive ischemic infarct, bedbound. So what went wrong? So this is the classic example of Chadsworth score. We have to remember anticoagulation in India is like this is the 49% mean time in therapeutic range, whereas in Sweden it is almost like 77%. So NOACs, newer anticoagulants have to be used. Now we are having freely available, 3-4 brands, and except for the mechanical valve and moderate to severe mitral stenosis, rest of the places we can use this molecule. Modern temple of cardiology is cath lab, and cath lab we have been doing very well so far. And so on one side is 46-year-old post CABG in 24 hours still sleeping, and 83-year-old post PCI is walking in 2 hours. So that is the advantage of PCI. This is about device closure of ASD and VSD, which is a reality now. Replacement of valve, so-called tower, is now a reality now. People are doing it. In our country, not many, but in America and all, USA and all, this has crossed almost like 1 lakh, more than 1,20,000. Now, so now the tower has taken over the aortic valve, surgical aortic valve replacement. So now we are, in 2020 onward, intervention have to be less and prevention have to be more. This is the presentation we did in last API conference. So we have to remember that all of us, all the students who are listening to me, they have to understand that some kind of research has to be done by them. Data collection, whatever case presentation you must do. We decided this, requested Nandini. We are sending a case and she was glad to have it and we presented this. What is the future? Future is that in future, there's going to be a continuous sub-specialization in pursuit of technical virtuosity and clinical excellence. The situation will be first both aggravate the escalation of cost and intensify the workforce shortage. Preventive measure based on the patient characteristics such as phenotype will expand. The prevalence of heart failure will grow further as the population is growing, the age is growing, and the more and more number of coronary heart disease and other things we are having. So there will be more application of pharmacogenomics. So this is our Living Heart project, which is a reality now, which is becoming reality now. Prediction beyond 2025 is more uncertain. However, it is likely that advances in genetics and genomics will allow the subclassification of disease, which will lead to genes-informed therapy. Identification of genetic markers will identify the individual at risk and will receive treatment accordingly. So, thank you very much for your kind attention. Any question or any queries or any comment? You are most
Sir, there is one query from Dr. Roshan.
Yes.
Can we thrombolize MI equivalent like D Winter or Wellness?
Not recommended so far. Because, we have very well-defined criteria for thrombolysis. One is ST elevation MI within such a stipulated time. And second thing is new left bundle branch block, which was not there. So LBVV with chest pain within a stipulated time it can be an indication for thrombolysis. Yeah.
Thank you, sir. I invite any student to ask any question. They may put in the chat box.
Guests like any guests like Dr. DP Singh or Dr. Wander or Dr. Das, are they there? Dr. A.M. Das, Amit Das.
Probably Amit has not joined. I think they have not joined.
Okay.
So any comment from any expert?
No, it is a marvelous lecture, Dr. Ajay. Thank you very much.
Sir.
And next 2 class of cardiology will go for cardiac arrhythmias.
Yes.
Bedside diagnosis and its management.
Right, sir.
So with these words, thank you very much.
Right, sir.
Thank you, sir. Thank you.
Thank you all. Thank you all.
Thank you.
Thank you, Sanjay ji. Thank you, sir.
Thank you. Thank you.
Thank you all, sir. Good night.